Thank you very much, Sandeep, and a very good evening to all of you. I would like to extend my thanks to the entire organizing team. And after having listened to the previous speakers, I think, as has been rightly mentioned, uh, I'd informed that you can show the slides, and so your team can present the slides. So I'll talk about the ARAMIS data and the final analysis. And as we know that the ARAMIS trial is trying to look at darolutamide plus ADT compared to placebo and ADT for non-metastatic CRPC. So similar to the previous two studies which were discussed very eloquently by both the previous two speakers. Next slide. Now the advantage of darolutamide over the previous two molecules, enzalutamide, apalutamide, is it also inhibits the AR like both of them, but it is structurally distinct. And that leads to three important features: low penetration of the blood-brain barrier, favorable safety profile, and low drug interaction potential. I think these 3 points are responsible for us to make us understand that this drug is different than enzalutamide or apalutamide. I mean, for instance, you find apalutamide has patients have falls, rash, and fractures. Enzalutamide patients have falls, dizziness, mental impairment, cognitive impairment, hypertension, fatigue, and severe fatigue. Now, and all of these usually tend to happen because of they being structurally different from darolutamide, and that becomes the advantage of darolutamide. ARAMIS is a phase 3 trial which looked at the safety and efficacy of adding daro to ADT for non-metastatic CRPC, like Spartan apalutamide or like Prosper enzalutamide. At the primary analysis, the primary endpoint of metastasis-free survival was met with a hazard ratio of 0.41. The median OS was around 41 months with daro versus around 18.5 and placebo, hazard ratio of 0.41, p-value highly significant. Adverse event profile was favorable, and the current presentation of ASCO 2020 looks at the pre-specified final OS and the safety data even after unblinding the primary analysis. So next slide. So we need to realize that this molecule is pharmacological distinct and has active diastereomers which target the wild type AR, and also several gene mutations which can be having resistance to the next generation androgen receptor therapies like enzalutamide or apalutamide. So it's able to target the wild type AR. It's also able to target several genetic mutations which may happen when a patient progresses on enzalutamide or apalutamide. It's able to minimally penetrate the BBB and therefore has less neurocognitive side effects. And a low potential for drug-drug interactions, because usually in patients of prostate cancer or elderly, you find these patients on statins or anticoagulants or antidepressants or calcium channel blockers, and their presence or absence does not make any difference to the usage of darolutamide. I think these 3 points are very, very important and would therefore tilt me in using daro over enza or apalutamide. Now, the ARAMIS study design was a double-blind randomized phase 3 trial, 1,500 patients randomized 2:1 to daro versus placebo and ADT. Now, the inclusion criteria pretty similar, be it Spartan or the Prosper trial. In September 2018, the primary analysis was done and the primary endpoint was clearly met, 41 months versus 18.5 months. Therefore, unblinding happened, and after unblinding, 170 patients, 1/3 of patients, the placebo arm, went on to receive open-label darolutamide. Now, we are now going to hear very commonly about what is called as hierarchical testing in clinical trials. When the primary endpoint is met, and if the hazard ratio is favorable and statistically significant, only then you'll assess the secondary endpoints. And that was what the trial looked at. So once the final and primary endpoint was met, only then you are going to formally assess the secondary endpoints. And what were the secondary endpoints tested hierarchically? OS, time to pain progression, time to first cytotoxic chemotherapy, and time to the first symptomatic skeletal event. So these are the secondary endpoints we are going to discuss today, which were tested hierarchically. So therefore, I think we need to understand that many of the ongoing trials talk about hierarchical testing. Therefore, we need to get familiar with this. So coming to the OS data, the first secondary endpoint, 6% advantage, absolute numbers, 77 versus 83% at 36 months, favoring darolutamide, or placebo hazard ratio of 0.69, p-value highly significant. Now, mind you, again, I told you, 1/3 of patients, 171 placebo arm, went on to get darolutamide when progression happened, when the primary endpoint blinding was done, because the primary endpoint was blood. So unblinding happened. A good significant patients on the placebo arm went on to get daro, and still you find an improvement in the OS. I think that's very, very important with this molecule, that despite unblinding happening and 170 patients going on, the placebo arm getting daro, you still find an advantage in OS. The other secondary endpoints, next slide please, looks at time to pain progression, time to first cytotoxic chemotherapy, and time to the first symptomatic skeletal event. And all of them uniformly favor the usage of darolutamide over placebo. So androgen deprivation therapy plus darolutamide was able to meet all the primary and the secondary endpoints, despite on the placebo arm, 1/3 of patients receiving daro, and despite hierarchical testing in this particular clinical trial. So then we are worried about the adverse event profile. And as I told you before, this molecule has several advantages because it is structurally distinct than apalutamide or enzalutamide. So coming to the adverse event profile, next slide. And as you can see, across all grade adverse events, all of them seem to be less than 10%. In fact, then 3%, 4%, 5%, 7%. Now, fatigue comes at 13.2%, but grade 3-4 is around 8.3%. So, final safety analysis hugely favors the use of darolutamide, and more than 90% of patients possibly will not have any troublesome side effect. 13% of patients may have some fatigue, but 8% of them only would have grade 3 or grade 4. Next slide. So let's try to compare with AR antagonists. Next slide. So coming to Spartan, where we had apalutamide, on Enza, where we had the Prosper trial, the enzalutamide. Now these are indirect comparisons, so we'll have to wait for data of 2 more trials which are comparing daro to enzalutamide. But in the meantime, we can do some comparison indirect, and you actually find no statistically significant differences. But having said that, when you look at absolute numbers, patients on apalutamide would have more falls, more rash, more fractures. Enzalutamide, more falls, more dizziness, more cognitive impairment, more hypertension, more fatigue or severe fatigue. And that's why in absolute numbers, daro seems to be better than APA or enzalutamide. Next slide. So to come to the conclusion part, in the phase 3 ARAMIS trial, daro plus ADT reduced the risk of death by 31%, despite a significant proportion of patients in placebo arm receiving subsequent life-prolonging treatment, including darolutamide. The 3-year OS, 6% advantage absolute numbers, hazard ratio 0.69. Additional benefit happened in all secondary endpoints, including time to pain progression, or first cytotoxic chemo, or the first symptomatic skeletal event. No new safety concerns identified in the primary and the final analysis. All adverse events are basically class-wide safety profile, but the advantage seems to be of using daro, because in absolute numbers, the adverse events seem to be very few. And so we have many similarities among the Spartan PROSPER, and ARAMIS as far as the enrollment of patients is concerned and the inclusion criteria. All three drugs also improved the key secondary efficacy endpoints, and therefore the primary differences lie in the safety profile of these molecules. And that's where I believe Daro has an edge over apalutamide or enzalutamide, including the fact that it seems to be having less penetration into the brain. It also seems to be having a very less incidence of adverse cardiovascular events, and more than that, very low potential for drug-drug interactions. So I would like to give, if I have to choose, I would tilt towards darolutamide because of its favorable adverse event profile. Otherwise, efficacy-wise against the prostate cancer, all three are equal from my side. Thank you so much.